Now we'll conclude our episode on aging with a discussion of end-of-life care. All of us are going to face end of life for ourselves personally, but more importantly for these discussions, the end of life of our loved ones, the people that we're responsible for and we care about. And for the in-depth discussion of this issue, we're going to go to an expert in the area, Dr. Ann Glass. Ann is an associate professor here in the College of Public Health in the Department of Health Policy and Management, and is assistant director of the Institute of Gerontology here at the University of Georgia. And maybe, first of all, you can explain to us about palliative care and how it's different from hospice care.
Well, hospice, actually the first hospice opened in the United States back in 1974, and it became a Medicare benefit around 1986. So it's been around for a few decades, but even it is still not well understood. It's actually an excellent program which provides comfort care for people who are near the end of their lives.
So hospice care then is when you've really kind of given up on curing someone and you've just accepted that and you're just caring for that person in time.
That's right, and that's one of the issues around hospice is that because of the reimbursement structure, you really do, as a patient, you have to give up on curative care, and you have to have physicians certify that you're within 6 months of the end of your life. And you can realize that for a lot of patients and families, that's a very difficult thing to accept. And therefore, there's a delay in referral to hospice, which is unfortunate.
So palliative care, in contrast then, is giving comfort to people. It probably could start earlier in this process and go all the way to the end.
That's right. Palliative care is really a holistic approach to comfort care. And the idea is that it could start earlier in the process while the person is still receiving curative care. One of the things that hospice and palliative care physicians and healthcare providers do extremely well is pain management, for example. And they claim they can help probably 95% of patients be at a level of pain that they can manage comfortably. So that's an important thing for people to realize too.
Yeah, well, that's really important. Is there any evidence to show that this is actually beneficial?
Yes, there is a recent study that was conducted at the Massachusetts General Hospital with patients with advanced lung cancer, and it was reported in the New England Journal of Medicine in the recent issue. And what they found was that when they did receive palliative care early in their illness, patients had a better quality of life, less depression, and actually many of them lived longer, despite the fact that many of them chose not to have aggressive end-of-life care.
Okay, when you say aggressive end-of-life care, that really sounds very ominous and aggressive. What do you really mean by that?
Well, in the context of this study of the lung cancer patients, it could have meant that they chose to continue chemotherapy beyond a certain point, or they chose not to go into hospice when they might have, as early as they might have. But it can also include their resuscitation preferences. And this brings up a whole area of CPR, cardiopulmonary resuscitation, and the do not resuscitate orders. And this is an area that, again, people do not get much education. Nobody sits down with you early on to explain what these different options mean so that you can make an informed decision about what you want for yourself or for your loved ones. And the unfortunate thing is, because of the way we see it portrayed on TV, the general public and even healthcare providers themselves have a very much inflated idea of what's going to happen when you get CPR. You're going to get up off the table magically and be able to go home. And the reality is that the chances of you getting up from CPR and going home with anything like normal brain function, a recent study showed were about 7%. And for frail older people, in most cases, it's going to be 0. And CPR can actually be a pretty violent procedure, and if people understood that, they might not ask for it.
Well, there's a lot of discussion now with the healthcare reform debate about all these resources being spent on the last 6 months of life. That really ties into this, doesn't it?
That's right. I think there's been research that shows when people understand their options, sometimes doing less aggressive treatment at the end of life actually leads to a better quality of death, a better end of life.
Well, so in other words, doing less sometimes gives us more.
That's right.
Yeah. I understand you recently conducted a survey of hospitals in Georgia regarding their palliative care programs. Could you like to share that with us?
We conducted a study with 128 hospitals that are on the Medicare.gov website, and we found that they reported to us over half of them did not know what palliative care programs were and did not offer palliative care. About a quarter of the hospitals did know what palliative care was and did not offer it, and then about 20% knew what it was and offered palliative care.
So how does that stack up with the rest of the country?
Not real well, unfortunately. A recent figure I saw for the United States was about 50% of hospitals are now offering palliative care, and we're at about 20%, so we have some catching up to do.
So we're really, Georgia compared to the rest of the country is less than half.
That's right.
And the rest of the country isn't where they need to be either.
That's
for
absolutely
comfort
right.
care.
Yes.
Well, if you wanted to summarize and just, a message that you would like to tell everyone about end-of-life care, what would that be?
Well, to individuals, I would really encourage people to seek out information about end-of-life care and what are your options so that we better understand it before anything happens, before you get into a crisis situation. Because once you get in a healthcare crisis situation, decisions are made very quickly, and if you don't know what you're asking for, you may have outcomes that are not what you wanted. And the other thing is, I hope that we will encourage our hospitals in Georgia to consider offering palliative care, because really all hospitals should offer it so that all patients with advanced illness can have access to it.
Okay, well thank you very much. This is a very important area, the end-of-life care that all of us will face. And the key really is planning ahead, and not ignoring it, but planning ahead and facing what is a natural part of the lifespan. Well, I think we've achieved our goal of learning about the aging process and how we can impact on that.
But are you telling me, Cham, that all of this money that I'm spending on this anti-aging cream is not going to help me very much?
Well, I think what Dr. Poon would have told us is that the fact that you cared enough to try to impact on the aging process is what was the key, and for you to make it into the centenarian study.
Well, for you, Cham, you don't have that much farther to go, do you? 20 years or so?
Well, thank you for giving me a goal. I would like to impact enough on my aging process to make it into the centenarian study.
Well, that ties in nicely to a couple of episodes we have coming up, one of them on cancer and the other on obesity.
And that's an example of issues that are not likely to get you into the centenarian study.
And it shows how important public health is and prevention in our communities to really improve population level health.
So thank you for tuning in this time. Look in your local listings for the next edition of PHI, Public Health Impact.